Welcome to This Week in Orthopedics. This week we are covering 10 notable papers spanning joint preservation and alignment, optimization of primary and revision arthroplasty, and key technical factors influencing soft tissue reconstructions. Let us dive in. We begin with joint replacement optimization, focusing on fixation methods, implant design, and infection mitigation. In a retrospective study, Bergio and colleagues compared cemented and cementless fixation for robotic-assisted total knee arthroplasty using a single robotic system and a uniform implant design. Analyzing over 2,600 consecutive primary procedures with a mean follow-up of 3.5 years, they found that 5-year revision-free survival was excellent and comparable between the groups, exceeding 98%. However, cementless fixation was associated with a nearly 80% lower risk of septic revision compared to cemented fixation, with no differences in aseptic revision, overall reoperations, or 90-day readmissions. This suggests that modern, highly porous cementless designs can significantly reduce infection-related failures without compromising short-term stability. Transitioning to total hip arthroplasty, we must consider the distinct challenges posed by prior hip surgeries. Wagner and colleagues utilized the German arthroplasty registry to compare primary total hip arthroplasty outcomes in patients with a history of prior ipsilateral osteosynthesis or prior osteotomy. In their matched analysis of over 14,000 pairs, they discovered that these two histories have completely different risk profiles. Prior osteosynthesis represents a highly complex conversion scenario, carrying a 7-fold higher risk of overall revision, a massive 17-fold higher risk of periprosthetic femoral fracture, and a nearly 4-fold higher risk of infection. For these high-risk patients, cemented and hybrid femoral fixation significantly reduced the risk of revision and periprosthetic fracture compared to cementless fixation. Conversely, prior osteotomy presented an intermediate risk profile, with a 2-fold higher risk of revision and a 9-fold higher risk of dislocation, but no significant increase in fractures or infections. Notably, reverse hybrid fixation in the osteotomy group was associated with worse outcomes, including higher revision and infection rates. The clinical takeaway is clear: do not pool these clinical histories during preoperative planning and lean towards cement-based constructs for patients with prior osteosynthesis. Moving on to implant design, Eichle and colleagues published a randomized controlled trial in Acta Orthopedica, comparing an uncemented ceramic-on-ceramic monoblock cup with a modular ceramic-on-polyethylene cup using model-based radiostereometric analysis over 5 years. While the monoblock cup demonstrated a statistically significant higher total translation at 5 years, with a mean difference of 0.71 millimeters, both cups stabilized after 3 months. Furthermore, there were no differences in rotation patterns, patient-reported outcome measures, or actual revision rates, confirming that the monoblock cup is a stable and clinically comparable option for younger active patients. Finally, we look at the surgical environment itself. A study by Firth and colleagues in the Bone and Joint Journal evaluated the association between surgical gown type and periprosthetic joint infection in over 9,000 primary hip and knee arthroplasties. Challenging the common assumption that disposable gowns provide superior sterility, they found that single-use surgical gowns were independently associated with a 73% increase in the odds of developing a periprosthetic joint infection within 12 months compared to reusable gowns. This finding highlights a critical need to reevaluate gown selection protocols and investigate the underlying factors driving this difference. Next, we turn to lower extremity alignment and knee joint preservation. In a study, Kim and colleagues evaluated whether coronal plane alignment of the knee, or CPAC, classification parameters could predict the development of knee osteoarthritis. Utilizing data from over 2,500 knees in the multicenter osteoarthritis study followed over 5 years, they found that while the specific CPAC categories themselves did not directly correlate with osteoarthritis development, individual parameters did. Specifically, knees that developed osteoarthritis had significantly lower joint line obliquity and lower arithmetic hip-knee-ankle angles. A joint line obliquity below the threshold of 171.6 degrees was associated with a 36% higher risk of developing knee osteoarthritis, illustrating that joint line obliquity is a critical factor in osteoarthritis pathophysiology and surgical planning. When surgically correcting alignment, the technique chosen can have unintended consequences on patellofemoral mechanics. Biner and colleagues published a retrospective study in arthroscopy comparing ascending versus descending tibial tubercle osteotomy during medial open wedge high tibial osteotomy. Evaluating 106 knees, they found that the ascending technique significantly decreased patellar height and increased the tibial tuberosity trochlear groove distance by over 2 millimeters, potentially altering patellar tracking. In contrast, the descending technique kept both patellar height and the tuberosity trochlear groove distance stable. While hinge fracture rates were high at over 43% in both groups, the stable patellofemoral parameters in the descending group suggest it is the preferred choice to preserve native patellofemoral alignment. Underpinning all of these alignment decisions is the need for highly accurate measurements. Favier and colleagues conducted a systematic review in the Bone and Joint Journal, evaluating computed tomography-based methods for measuring femoral version and tibial torsion. After reviewing 7 femoral version and 9 tibial torsion techniques, they identified the Murphy method for femoral version and the Goutalier method for tibial torsion as having the highest inter- and intra-observer reliability and clinical utility, recommending their adoption as the universal standard for clinical practice and research. Our third theme covers soft tissue reconstruction and trauma management, where patient selection and procedural timing are paramount. In the knee, Renfrey and colleagues investigated whether adding a modified lamellar lateral extraarticular tenodesis to a primary quadriceps tendon autograft anterior cruciate ligament reconstruction improves outcomes. In their retrospective comparative study of high-risk patients, such as those with high ligamentous laxity or those returning to pivoting sports, the addition of a lateral extraarticular tenodesis halved the overall graft failure rate at 2 years, reducing it from nearly 30% in the isolated group to under 15% in the combined group. The combined group also had a lower rate of residual pivot shift and returned to sports nearly a month faster, averaging 8.8 months compared to 9.7 months, though there was no difference in actual graft retear rates. In the shoulder, Holt and colleagues examined how the timing and technique of a prior rotator cuff repair affect the outcomes of a subsequent reverse shoulder arthroplasty. Analyzing over 100 procedures with a minimum 2-year follow-up, they found that patients who had a prior arthroscopic repair achieved significantly better functional outcomes, including a 13-point higher American shoulder and elbow surgeon score, greater forward elevation, and greater external rotation compared to those who had a prior open repair. Additionally, a longer interval between the initial repair and the subsequent arthroplasty was beneficial, with a 10-year increase in time independently associated with a 7-point higher postoperative score and better external rotation. This suggests that arthroscopic techniques preserve tissue quality better for future reconstruction, and delayed conversion yields superior functional results. Finally, we address the critical systemic impact of orthopedic trauma in the geriatric population. Haugen and colleagues published a Danish nationwide cohort study of over 72,000 patients aged 65 and older who underwent hip fracture surgery. Within 30 days of surgery, nearly a quarter of all patients experienced a medical complication, most commonly pneumonia at 6% and urinary tract infections at 5%, while 4% experienced a surgical complication. Crucially, the occurrence of any medical or surgical complication was associated with a dramatic 3-fold increase in mortality between 31 and 60 days post-surgery, rising from 3% in those without complications to 11% in those with complications. This highlights the absolute necessity of rapid, multidisciplinary care pathways to detect and manage these complications early. If you only have time for one paper this week, make it the 5-year survivorship analysis of robotic-assisted total knee arthroplasty by Bergio and colleagues in the Bone and Joint Journal. This study provides compelling, large-scale evidence that cementless fixation in robotic-assisted total knee arthroplasty significantly reduces the risk of septic revision without compromising overall implant survivorship, offering a major clinical advantage for modern knee reconstruction. Here are the key takeaways from this week in orthopedics. First, when performing primary robotic-assisted total knee arthroplasty, consider a cementless design, as it demonstrates comparable 5-year survivorship to cemented designs while significantly reducing the risk of septic revision. Second, tailor your femoral fixation strategy in conversion total hip arthroplasty based on prior surgery. Patients with prior osteosynthesis are at exceptionally high risk for periprosthetic fractures and benefit from cemented or hybrid constructs, whereas those with prior osteotomies represent an intermediate risk profile. Third, in high-demand patients undergoing anterior cruciate ligament reconstruction with a quadriceps tendon autograft, adding a lateral extra-articular tenodesis can cut overall graft failure rates in half and accelerate return to sport. Fourth, carefully evaluate preoperative patellofemoral alignment before performing a medial open wedge high tibial osteotomy. Utilizing a descending tibiotubercle osteotomy helps maintain stable patellar height and tibial tuberosity trochlear groove distance compared to an ascending approach. Finally, recognize that medical and surgical complications occur in over a quarter of hip fracture patients and are linked to a threefold increase in short-term mortality, highlighting the absolute necessity of early detection and personalized clinical pathways. That's your roundup for This Week in Orthopedics. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials,